Welcome, everyone, to Creating a Family. Talk about adoption and foster care. Today, we're going to be talking about common special needs in international adoption with Dr. Kimara Gustafson. She is an assistant professor in the Department of Pediatrics at the University of Minnesota. She has her Master's of Public Health, and she also has an appointment at the University of Minnesota Adoption Medicine Clinic. Dr. Gustafson, welcome to Creating a Family. Thank you so much for talking with us today about a topic that we get a whole lot of questions on.
Yeah, of course. Thank you for having me.
We're going to start by talking about not only what the common special needs, but also just briefly, what are they and how involved is post-adoption care, be it through surgeries or through therapy or through parenting challenges? Because I think that's what parents need to think about when they're checking off the list of all the things that they are willing to accept, or they have a referral of a specific child that has a condition. It seems to me that they need to be thinking about how the impact will affect the child, how it will affect their family, what type of therapies and surgeries, or even if that would be required. So I've got a list of common special needs. So we're going to just go down the special needs, and you tell us just generally what it is, and then what's involved with it. People will say, "Well, how big of a special need it is?" I always
Sure.
object to that because I'm not really sure that that's the way that we measure a need. But we can talk about how involved the care would be. All right, so let's start with cerebral palsy. What exactly is cerebral palsy?
Yeah, so cerebral palsy is usually thought to be more of kind of what we call a motor disorder. So it impacts kind of the way that your muscles move and kind of the amount of tone, like how tight or how loose your tone is. It's usually thought to be due to a insult to the brain, sometime kind of around the birth process, or maybe shortly before or kind of during the birth process. And it can vary in terms of severity or kind of degrees. So we think that it can only involve kind of the legs. It can do all, the arms and the legs, or it could involve just like one side of the body, so the right side or the left side. And just like with most of the conditions that probably we'll touch base on, there's a kind of a spectrum. And so there are people who can have kind of a mild case of cerebral palsy. And when we see that, typically we think that kind of cognitively, there's less likely that there's any impact. So that person kind of, from a cognitive standpoint, should be expected to be on the same trajectory, but would have more kind of physical limitations, or potentially need more kind of therapy geared towards their physical needs. But if they have more motor involvement, then there's more likely to be also a cognitive involvement as well. And so that's kind of something that potentially families would want to consider. The other thing too is that sometimes CP can be under kind of I don't want to say hidden, but it's like for a younger child, if they don't have a definitive diagnosis that the child has CP, sometimes it'll be under what we call hypoxic ischemic encephalopathy, or HIE. And that is a condition that we think of where the baby, right around the time of birth, it could be from birth trauma, that they have kind of a lack of oxygen, kind of transiently, but can impact them. So that's something that not uncommonly we'll see, where a family will send us a referral that has a diagnosis already of HIE, and then we go on to say that kind of signs and symptoms are pointing in the direction that this child has now kind of developed CP, likely as a kind of sequelae from that HIE.
Okay, and isn't cerebral palsy also more common in premature births?
It can be, yeah, again, because the premature infant, their brain is a little bit more kind of sensitive, or just underdeveloped. And so CP can be an insult of any sort. So either like lack of oxygen, or if there was kind of a transient stroke or clot. And versus the HIE is usually refers to just lack of oxygen. So yes, if there is a premature infant, or an infant that was growth restricted in some way, that they're going to be at higher risk that their brain will kind of incur that insult that leads to CP.
Gotcha. Okay. how involved is the post-adoption care for cerebral palsy?
Yeah, so again, it's on the spectrum. So for mild cases, it would likely just be a matter of ongoing physical therapy, maybe some occupational therapy, and then depending on kind of their muscle restriction or kind of muscle condition, they might need help from orthopedics, not so much from a surgical standpoint, but for splints or kind of casting to help with positioning of the limb to the extreme. And then those are the kids that we see that they might be wheelchair bound. So that might be limiting in terms of kind of mobility and could have impacts for the family in terms of like the layout of their house and what kind of, we had a family recently ask, what's the best minivan for a wheelchair? And I was like, I feel kind of dumb. I should know the answer. So I kind of sent out that question to, the group of parents that was like, they had wheelchairs. They said, what's the best mini, and so those are things that, the family was realizing that we need to get a new car. But it can be all the way to where they'll need to see someone, a physician multiple times a year, maybe to get certain medications that help with kind of muscle relaxants or treatments. And then again, on the severe end, because CP is caused by an insult to the brain, definitely not everyone with CP has seizures, but they're higher risk for seizures. So we do see children that have CP and have kind of a concurrent seizure disorder. So then that would be kind of an added specialist that they need to follow and added medication and such.
All right, excellent. Now, heart issues. Again, everything we're saying is on a spectrum of severity, but in general, what are some of the more typical heart issues you see in international adoption?
Yeah, so very typical, we'll see what we call PDA or patent ductus arteriosus, and sometimes we see a PFO. And these are both kind of parts of the heart anatomy that are open before an infant is born, and then should close shortly after an infant is born as they transition from the blood supply from the biological mom to breathing on their own. And so again, like if a baby was born premature, sometimes the PDA won't close the way that we expect it to, or that PFO doesn't close. And so if it persists, then it's usually kind of diagnosed as a small ASD. And
What does ASD stand for?
Yeah, atrial septal defect.
Gotcha.
And so those are probably the most common that we see, and oftentimes those may not need any kind of intervention, or if they do, it would be kind of more of a minor surgery and potentially even as simple as, and I know any surgery doesn't sound simple, but something like they could go to a cardiac cath lab as opposed to kind of open heart surgery.
Okay.
Then kind of moving down the spectrum, so you can have larger ASDs, and then VSD, which is a ventricular septal defect, which is kind of the lower part of the heart. So, and then once we get past that, then it tends to get a little bit more complicated. And so similarly, kind of the follow-up and kind of potential treatments can be a little bit more involved when we start to get away from kind of those top four.
So with those four, they require general either nothing. The child will be with the hole in the heart would be healing on its own, or it would require surgery. And the surgery, it sounds like, could vary between something relatively simple to full-blown surgery on the heart itself.
Yeah, and sometimes it depends on, so definitely depends on the size of the defect, but also we kind of put it into the context of it can depend on the age of the child. So if a child is younger, then like with an ASD or VSD, we would maybe potentially give them a chance to see if that condition is kind of self-resolving. When we get kind of to an older age, so usually when they're kind of grade school and older, the likelihood that it's going to kind of quote unquote fix itself
Mhm.
decreases. So then that is one where, again, depending on kind of the size, we would recommend that the family talk to a cardiologist about, is this something that can just be followed, or does it, really need to be addressed? And oftentimes we look to see, we can get a little bit of a sense from kind of some of the medical information that's available pre-adoption, kind of that pre-medical review, looking to see, how is the child doing overall? Are they growing? Are they developing? If the heart is struggling, it will definitely have impacts in terms of growth and development. And so sometimes we can pick up kind of these little hints to see, um, likelihood of the child needing more kind of support and therapy versus less.
So a child with a heart issue, do they have either surgical, whether it's surgically repaired or if it heals on its own? For the ones that you've mentioned, the four more common heart issues, does the child have a normal life expectancy and a normal life? In other words, can they partake of the activities of a normal childhood, and will they live as long as other children?
Yeah, so that's a great question. And it really depends on the kind of congenital heart defect that they have. And then depends on whether or not it's been addressed or partially addressed in their pre-adoptive country,
Hmm.
at what age, and kind of how well was the surgery or intervention, how successful was it, and then those factors, we can see ones that even if they have a major defect and it was addressed, very early on in kind of the early infancy period, and they've been doing well, that they may not have life expectancy all the way, to the full life, but it would be well into adulthood. But uh, but then we can see other ones where if it's not repaired, and what I'm thinking of is that we oftentimes will break the heart into kind of two categories. One being hypoxic, meaning that their body is unable to get enough oxygen to their whole body, or kind of non-hypoxic. And so if they're in the hypoxic category, we know that the longer that they go with kind of suboptimal levels of oxygen, that can have an impact on just the way that their organs are functioning, and then specifically how their brain is functioning and growing. So those people would more likely have kind of a cognitive impact with the heart condition, and then more likely would be thought to have kind of a shortened life expectancy, and maybe depending on the severity again, may not be even into adulthood.
Okay. And with all the special needs we are talking about, keep in mind that you would obviously be needing both pre-acceptance of a referral, and even perhaps if, as you're checking off the list of what you're willing to accept, you need to converse with a adoption medicine clinic, uh, or your pediatrician, but in particular, an adoption medicine clinic to help you understand more specifics. And especially that is the case after you have a referral because you have a child and you have the records from that child. So obviously
Yeah, and
take that to a clinic and to a doctor who can help you evaluate the specifics for this child.
right, I totally agree. And we find, so we do, over 30,000 pre-adoption reviews kind of since the inception of the clinic, about 30 years ago. And with the high number of pre-adoption reviews that we do, we found that part of the reason that families like it is that kind of their comfort level and kind of the expectations that they have pre-adoption, pre kind of meeting their child, are just kind of significantly improved in terms of what to expect and what the kind of the first couple weeks or months will be, and then even down the road in terms of years and kind of decades after, versus where we also will see families in clinic that have maybe not had that pre-adoption review, and they I think are a little bit more kind of a deer in headlights in terms of,
Hmm.
okay, gosh, there's all these specialists I need to see. The one thing I want to kind of mention that you touched on, which I think is a great thought, when one kind of the way that I start too from families is when you're thinking of the list of, kind of what are conditions that you feel comfortable, both in your home, but I think logistically thinking about
Hmm.
where you live. And so what are
Yes.
your resources? If you are in the middle of nowhere and the kind of the closest regional hospital is hours away, um, then maybe a kid with a heart condition is not a great fit for you, because the closest pediatric cardiologist could be in the next state. Versus if you live in a metro area and you have access to kind of a whole wealth, then that's not as much of a concern. So that's something that I tell families, because depending on families, if they have other children, I know that I have 3 boys, and I know that having kids is all about being in the car and just shuttling small bodies around all over the place. But, so now do you want to add in other doctor's visits, therapy visits, and if any visit requires at least, an hour drive, that's going to be a significant amount of your time.
It's such a good point.
Yeah.
I think that's a really good point, to think through the logistics of what the special need may require. If it's a very involved heart condition and you have to go to a specialty hospital, a hospital that specializes in pediatric cardiology, and that's going to require out-of-state travel. How can you handle that? How, from a job standpoint, from a family standpoint? So all of those are just are so important. So thank you for raising them. All right, cleft lip and cleft palate. That used to be a fairly common one that we saw coming from China in particular, but other countries as well. Explain what cleft lip and cleft palate is, and what the typical care regime would be to repair it.
Yeah, so we still see it not too infrequently. So cleft lip and cleft palate is a condition where kind of the body, as it's forming before birth, kind of the face starts on the outside and kind of comes together. And so that for some reason it doesn't fully come together kind of in the lip area, kind of right under the nose. And then the palate is that kind of hard part on the top, the roof of the mouth. And so it doesn't kind of fully close there as well. We oftentimes, from China, it's both cleft lip and cleft palate. And from other countries as well, depending on the country, the lip is oftentimes repaired. Sometimes it's not repaired very well, so they would need kind of like a plastic surgeon follow-up or kind of revision. But the palate is left unrepaired. And so that's something that definitely for their families, they would need to address after a child comes home. It can have implications in terms of how well a child is feeding, and then speech related, just because they can't quite form the sounds or be able to use their tongue in the way that we would hope. And then also we always want to make sure that they get their hearing tested, because they can have, because of kind of the defect in that mid-face area, it can extend to that they have chronic ear infections or potential fluid in the ears that's causing hearing difficulty. And then sometimes we get children that are young enough that we don't quite know what the impact, if any, it will have on their teeth, but definitely that would be a child that would need to establish with pediatric dentistry and then orthodontics down the road.
Mm-hmm. Because it can also be the absence of teeth. So at a minimum, usually a number of surgeries, and then dental and orthodontia.
Yeah, and oftentimes, especially in larger kind of metro areas, there's what we call kind of a comprehensive cleft lip palate clinic. It's usually run through the ear, nose, and throat service. And so that's one where they pull together like the kind of the ear, nose, and throat surgeon. Sometimes they have plastic surgery or oral facial maxillary surgery. Then you have speech and language therapists, the hearing specialists, and then dentistry.
Mm-hmm. Yeah, that's so. Knowing that there is a cleft palate clinic, cleft lip or cleft clinic, would be helpful. Moving on to developmental special needs. Let's start with Down syndrome.
Yeah, one more point I wanted to just make about the cleft condition is that about 25 to 30% of kids with clefts, the clefting itself can be associated with a syndrome. So sometimes it's just kind of a physical, kind of anatomical condition that's, would require repair, but cognitively, kind of developmentally, we don't expect them to be any kind of different than their kind of non-clefted peers.
Mm-hmm.
But there is that kind of 25 to 30% of kids that it might be part of a larger syndrome, and some of the symptoms can be associated with, kind of cognitive delays or developmental delays. And so again, that's something where if families say, yes, we're okay with cleft lip, cleft palate, they might be surprised if they get a referral, but then they say, no, we don't want all these syndromes. They might be surprised if they get a referral that seems a little bit more complicated than kind of just a simple clefting.
So be aware that cleft lip and cleft palate um, can be associated with syndromes that also infect development and brain development and intelligence and other things such as that.
Yeah, and that's one where, especially for the clefting, because families, I think, historically, like when we used to see more clefts from South Korea, and those it was usually kind of associated with just the kind of anatomic. So if you're speaking to parents that have older kids that had a cleft lip palate, their experience might be, oh, we just came home, we had a couple surgeries, and otherwise now they're great and they're in high school and they're going to go to college next year and yada yada. And so, but we know that there can be just a higher risk of syndrome related versus kind of the general population. And so
Mhm.
that is one that specifically, if a family is going in with the expectation that it's just a physical abnormality, I say you want to make sure that you're reading that pre-adoption review very closely, or kind of the medical information closely, so that you're not surprised that you're bringing home a child that you think is just anatomic, but it
Mhm.
could be part of something more.
Good. Okay, excellent. Now let's talk about Down syndrome. We all know that Down syndrome is a genetic defect, but what are some other things that parents? So when people are adopting a child, they are anticipating developmental delays, obviously,
Yeah.
or developmental impairments, not just delays. What are some other things they should anticipate when accepting a referral of a child with Downs?
Yeah, so you're right. I think that when we have families that we have a pre-medical review for Down syndrome, they are already very well versed in terms of from kind of the genetic and developmental standpoint of the condition. The thing to know that it can be associated with other issues. So we always recommend that they be evaluated just to kind of rule it out. They're associated with heart defects, digestive system, so kind of intestinal and stomach issues, ear infections, hearing issues, eye disease, including cataracts, and uh, higher rates of having difficulty with nearsighted or farsightedness, obstructive sleep apnea. There's a very small percentage, but increase versus the general population of certain types of leukemia, and
Oh,
then thyroid dysfunction. And so this is one that if it hasn't been done in the pre-adoptive country, we definitely would want to check. And usually, some of it has been evaluated. So oftentimes we'll see where they have had a heart evaluation or an evaluation of their hearing. And then there's kind of preventative care guidelines for children and young adults and adults that have Down syndrome that they would need to continue to follow it. So that would be something they would partner with their, primary care provider.
okay.
And again, there's, a very wide spectrum in terms of the, kind of cognitive attainment for children with Down syndrome. So some, they might be more severely cognitively impacted versus others, it's mild. But unfortunately we can't always predict, with a young child kind of which end of the spectrum that they will end on.
Yeah, I'm glad you pointed that out because there is such a wide variety of degrees of impairment. How do you know if the child is older, then you have a better feel, but if the child is younger,
Yeah.
you have to assume that you don't know, and no amount of um, of of post referral review with a specialist is going to be able to answer that question.
Yeah, and that's one is one that I definitely have some kind of empathy for the family, because we know that just in general, when we get a child, if we're able to bring a child home when they're younger, kind of the potential for intervention and support has better potential impact in terms of their future a kind of adult attainment. But then at the same time, like you said, that if we have a child that's very young,
Mhm.
we don't quite know what their kind of inherent trajectory will be.
Yeah.
So it's a little bit of a kind of unfortunately, that they're kind of stuck
Yeah.
between both sides. But definitely, the earlier that we know and we can intervene, we always think is kind of
Yes.
has better potential.
Plus, we're moving a child earlier from a institutionalized setting, which we know is not good for children regardless. So, yeah, it cuts both ways. Let me remind everyone that this show is brought to you and underwritten by the support of the Jockey Being Family Foundation. Post-adoption support programs are vital to helping to preserve families. However, the availability of these programs is not always communicated clearly during the adoption process. And legal professionals and judges are essential to encouraging the use of these services. And we know that families do better when these services are provided. As permissible by law, and it's not, that depends on where you're at, but judges and court clerks and adoption agencies can order backpacks through the Jockey Being Family website. And these backpacks are free, and they can be shipped to the courthouse for adoption day and can be handed out by the judge or the clerk or whatever. And of course, the agencies can also get these. And they're high quality backpacks. They've got the child's initials, but most important, inside they have post-adoption services. They have resources, post-adoption resources for families. To get more information, you can go to their website, jockeybeingfamily.com. All right. How often do you see autism as a diagnosis on a child that's been referred?
So great question. We don't. I don't know if I've ever seen a child that's come with a diagnosis of autism.
Yeah, I haven't
So,
either. So that's interesting.
yeah.
And why is that?
Well, so I don't necessarily know, the developmental kind of availability, or sorry, the availability of developmental specialists in these countries is pretty low.
Hmm.
And so, oftentimes if we're asking that a child be formally screened by a developmental specialist, in many places, like in China specifically or in India, it's very unlikely that that's going to happen.
Hmm.
And so I think that's part of it. And then again, part of it is that, uh, as you had mentioned or kind of alluded to, that we know that there might be some kind of maladaptive behaviors that are developed just
Hmm.
from institutionalized care.
Yeah.
And so we have seen children that would meet criteria for autism, you know, based on kind of the way we diagnose, but it's more due to the institutionalized care than kind of that they have underlying autism.
Hmm.
Um, but that being said, we've also seen children that, you know, it's suspicious or has become clear kind of over time that they
Hmm.
are very likely autistic.
So
And
the absence of an autism diagnosis in your referral and your medical paperwork that you get with a child is not necessarily reflective of much because we're not going to, it's seldom diagnosed abroad.
correct,
Yeah.
correct.
Okay.
And so that's where sometimes it is, or not sometimes, but that's where I feel like it helps to have kind of a expert review of the chart, because you can look to see even at the younger ages developmentally if there's some kind of red flags or things that are kind of piquing your level of suspicion in terms of autism. And then oftentimes if we do hear or kind of see things that might be a little bit of a concern, I will always try to request video, and say, can we have video of the child moving about, interacting with other children, interacting with their caregivers, um, to get a kind of a sense of, um, you know, those more subtle signs that might not come up on the review. And then, we always, if possible, will ask, can we make sure that we're screening them for any hearing issues? Because, if they can't hear, then maybe that's a reason why they're not interacting and such.
Mhm.
But I would say that most of the children that we catch that are kind of the high likelihood of being autistic, it's a family that has started to follow along, or is in the pre kind of match period, and maybe has even gotten as far as accepted the referral, and then in that waiting period before they're bringing the child home, they're getting updates and they're getting videos, and as the child grows, we're saying, well, this is pretty consistent behavior,
Mhm.
or the behavior is becoming more concerning because as they age we would expect them to do more.
Mhm.
That's usually, in my experience, how we sometimes kind of come to that diagnosis.
Okay. And how can you tell whether a developmental delay is something that is caused by the pre-adoption living environment, and how much of that is going to how much of that is going the child with good loving care and good support in a home, the child will outgrow.
Yeah, so usually what we ask is we say, how does this child compare to the other children in the institution? And because oftentimes the caregivers in the institution, even if they don't necessarily say, oh, yes, we know that this child has autism, they kind of have a sense of there's something about this kid that's a little different than the other
Mhm.
kids. And
Yeah.
so, if everyone's kind of got a mild delay or, the behaviors are, kind of mildly maladaptive because of the setting. For the most part, those kids we think have the potential to kind of rebound and recover with the right intervention, right support. But the ones that are autistic, generally, they'll even be a little bit more pronounced. And to the point where the orphanage caregivers will say, that's the one that is a little bit trickier to deal with, or
Mhm.
definitely kind of stands out compared to the other 2 or 3 year olds that we're seeing.
Okay, excellent. Now, hepatitis B and C, how common is that, and what is the prognosis?
Yeah, so we haven't actually seen a lot of hepatitis. I would say the main country that I've seen it in recently would be Haiti, um, and some of it was just that we didn't have pre-adoption lab findings. So that I think that there wasn't really pre-adoption screening available to the family. I would say that previously we used to think that hepatitis was a more serious condition, and definitely, domestically, if a child is born here, we always try to vaccinate them shortly after birth with hepatitis B, or we screen all pregnant women for hepatitis B, because the most common kind of means of transmission for a child is uh, through pregnancy and during kind of the birth process. Um, but I will say that both hepatitis B and C are now, I think, in the gastroenterology world, starting to be considered more likely a chronic condition. So not necessarily life limiting in the sense of that they're not going to make it to adulthood, but they'd
Mhm.
have more complications as an older adult. Hepatitis C, there's a recent medication regimen that has been approved, I think, on the adult side, and so they're hoping it's going to trickle down to the pediatric side, but is essentially thought to be curable. So now it's considered not necessarily a chronic condition, but something that has the potential to be cured. And then I think the thought is that they might be able to translate that over to hepatitis B. So what I've been telling families um, is that those I'm not as concerned about it. We would definitely want that child to follow along with a pediatric gastroenterologist, and that their risk of liver dysfunction, especially as an older adult, and then they have a increased risk of certain types of liver cancers. So again, would need to follow closely. But historically, that was thought to be more of an issue, and that the likelihood would be that they would need potentially liver transplant. We're not seeing that as much because we have kind of more medications and treatments to better treat it. And then the other thing I tell families is that, this treatment for hepatitis C has really come down in the last like 10 to 15 years. And so if a child is very young and then coming with hepatitis B or C as a young infant or young child, the potential that, 10, 15 years from now, we discover something even better is there. And
Mhm.
so if kind of in my hierarchy of things to consider, that one is pretty low, and in my mind, one that I think could be relatively well easily managed.
Okay, what about HIV now? There's been so many advances, but have we overplayed those in the media to where it's no longer a threat to a person's life? So what do we know about HIV?
Yeah, so similarly, HIV is now thought to be kind of a chronic condition. And again, for HIV and hepatitis B and C, these are ones that can be transmitted most commonly through, kind of bodily fluids, so blood and other bodily fluids. But what I also tell families is the risk to the immediate family is is pretty low, especially if the conditions are under good control and under good medical management. So something that sometimes families will ask me, well, we have other children in the house. Is that something we should be worried about? Or what are the implications for my child at school or kind of after school activities? There should be no restrictions from that standpoint. And there's no really increased risk for the parents or, any siblings, potential siblings. But yeah, getting back to HIV, it's something that we now think of as kind of a chronic condition. Again, they would need to follow with kind of immunologists or infectious disease specialists and would need to potentially take medication lifelong. But I think of it similar to like diabetes or certain kind of more benign kidney conditions. Is not something that should really kind of shorten their life. The implication sometimes that families think about is that what happens when they get to adulthood and they think about partnering and potentially having their own children. So that is something that needs to be considered. But I think that definitely the infectious disease and immunologists I work with, commonly they say that that's something that oftentimes they start having that conversation kind of with the child early on, and there are ways in which they can have a full life as an adult without feeling like they have any restrictions.
Okay. And let's talk about some of the more common orthopedic issues. And the ones that come to mind are clubfoot and limb and digit differences or
Yep.
deficiencies. Are those how common are clubfoot and limb issues?
Yeah, so we don't see it as commonly anymore, but we still do see some. So those are really thought to be just an kind of anatomical abnormality. So oftentimes it has to do with positioning of the child in the womb prior to delivery. That sometimes that if they're positioned in a certain way, or if there's not maybe quite enough amniotic fluid, that the foot is not allowed to grow in the way that we would hope. And so that's something that uh, can be sometimes treated just with like casting and helping the foot to kind of reposition once that external pressure is gone after the child's born. Similarly, for like limb or digit issues, that's typically caused by a condition called amniotic band syndrome, where the amniotic fluid actually creates kind of a band in the womb and will such that it makes it so that the fingers or the hand can't grow. And so it's usually more of kind of a cosmetic. A lot of times it's a pretty amazing when these kids come, they're kind of very well used with that limb. And so it would be kind of amazing for me to see and for others to see like how well they use it, even if they're missing, most of their fingers or, even their whole hand, they've been able to compensate well.
Mhm.
So and then nowadays with the kind of the way that we're advancing in terms of prosthesis, there's a lot of kind of options for families in terms of different prosthesis that a child can use to help to compensate if need be. But some of the children don't even really need a prosthesis. It would be more like cosmetic if they
Mhm.
wanted it.
But again, something that families should consider the logistics of if their child does have, I mean, even if it's just for cosmetic reasons, that they would want to be able to have access and get to because the prosthetics would take both training as well as fittings and
Correct.
things like that. All right.
Yep.
All right, let's talk about albinism. How common is that, and what is the treatment, and what else accompanies? Is it just cosmetic? Or are there other conditions that also are associated with albinism?
Yeah, so I wouldn't say that it's extremely common, but I have seen a couple pre-reviews, over the last couple years. So it's a condition usually caused by genetic that leads to kind of the lack of or a decreased amount of pigment in the different parts of the body, so the skin, the hair, and the eyes. Kind of depending on which country they're coming from, it can be more kind of immediately obvious or not. So I've seen some children that are coming from kind of the African countries where we expect that they're going to have more melanin or coloration in their skin, and so it's kind of more immediately obvious. Whereas I've seen some children coming from China where the skin kind of at baseline is paler. And so if you don't look closely, kind of the hair maybe looks blonder as opposed to white. So it's not like immediately obvious that they have is albinism to kind of the untrained eye. Most common things that are associated with it that would definitely need to be evaluated would be that there's a high rate of visual impairment because of the color, like the pigmentation and the way that that works in the eye. And so it can be anywhere from mild, where they just need glasses, to severe, where they're essentially legally blind. And so that's something for families to consider, because definitely, if you have a child that's legally blind, that's going to be lead to kind of greater implications in terms of like short-term and long-term, and the resources that they will need. And then practically, the other thing that needs to be considered is that their skin, because of the lack of pigmentation, is much, much more sensitive to sun exposure. So families would need to be very vigilant about kind of skincare, and that child would need to be followed by dermatology kind of on a regular basis. Doesn't need to be super frequent, but would need to establish with pediatric dermatology kind of early on. And then the last thing would be, again, social implications. So that one's a little bit kind of more nebulous and kind of hard to say, but this is a child that is already going to have some kind of the social concepts in terms of being internationally adopted and likely not looking like their family. But then if they are looking to kind of find kind of their quote unquote group, and let's say that the child is adopted from Congo, and their group is very dark skinned at baseline, that now all of a sudden they're kind of even the odd duck out within that group too. So those are just things to kind of think about for the family. Then like I said, it's more nebulous, so I can't kind of say that every child that has albinism is going to have issues with kind of their social concept and whatnot. But
yeah, no, but that's parents need to consider that. What are some other common causes of vision impairment, and how common are they in international adoption?
Yeah, so we can see some congenital glaucoma or cataracts. Sometimes it's due to kind of infectious disease around the time that the child is before they're born. But I don't see a ton of vision issues. Usually, if they do have a kind of a known vision issue, it's potentially associated with another syndrome, so like Down syndrome or albinism. I haven't seen a lot of kids where they are coming with just kind of the vision as the only issue.
What about hearing?
Oh, so hearing is pretty common. So we know that children, especially children that are living in an institutional setting, are at higher risk for kind of undiagnosed ear infections. Just that kind of, if you think about kids in daycare, they're always sick, and so if they have kind of recurrent or chronic ear infections that aren't diagnosed, so they're at higher risk that might cause some damage, either kind of temporary or permanent, in terms of their hearing. So when so we oftentimes will see speech delay, like a kind of a mild speech delay with these kids. And again, we're trying to piece out, is it because of, lack of opportunity and the institutionalized care? Or is it because they just can't hear? So not unfrequently we'll ask if we can get kind of a formal hearing test just to rule out hearing as an issue. If it is a matter that they have just a kind of a physical blockage, so like extra fluid or whatnot, that usually is easily corrected. They can get ear tubes or other kind of procedures to help with that. But then goes all the way to the spectrum that they have kind of a nerve dysfunction for their hearing. And so what I'm thinking of most commonly is that there's a infection called CMV that can be kind of higher risk for pregnant women. For adults or someone who's pregnant, CMV usually feels like you have a really bad cold, but unfortunately can have greater implications for the unborn child. And the most common cause, or kind of most common implication, would be hearing loss or kind of hearing impairment.
Gotcha. And you may or may not know about, depending on the age of the child, you may or may not know of a hearing loss, although there's usually evidence in the file that would indicate.
Yeah, so the most common kind of hint of hearing loss is that they have a speech delay, because if you can't hear, then you can't kind of hear the sounds that you need to be able to reproduce. And so speech delay, even in younger infants, we can be translated to that they don't babble a lot, or they don't turn to sound, or they don't kind of um, try to interact. So again, going back to the autisms, that's why we also, for children, that there's a concern that they're not appropriately interacting with their surroundings, we always want to make sure to check their hearing, because it could be something as kind of simple as that they can't hear,
Mhm.
versus that they have autism.
Okay. So from the standpoint of treatment, if you have a child, it depends on the cause of the hearing loss. If it's a matter of fluid in the ear, as you point out, that's relatively easy. Um, uh, Tubes in the ear and or medication or whatever.
Hmm.
But if it is caused by nerve damage, then you need to be prepared that your child will have a permanent hearing loss, and that would involve things like special education, learning sign language, and all that goes with that.
Yeah, and for some of the kids we have seen, they have been fortunate they've been able to get cochlear implants, even in their country, pre-adoptive. So there are treatments that can be done to kind of augment, hearing aids, or even to the end of the spectrum of having an implant to kind of provide another means to kind of restore their hearing. But families should know that there are certain types of hearing impairment that are not able to be fully corrected or correctable at all. So I know that with cochlear implants, I think kind of sometimes the population thinks, oh, like even if you can't
Mhm.
hear, there's a way to fix it, and that probably is the case for the majority. But there's always going to be that minority that might not be able to hear.
And cochlear implants aren't like it restores your hearing to what what the average person hears. It certainly improves, or it can improve, but it's not the same as normal hearing.
Yeah, it might not be. And then the other thing too would be, again, we think about when was the intervention made, at what age is the child. So if they're kind of pre-verbal or post-verbal, that can have implications on their speech.
Mhm.
And if what's difficult is sometimes these a lot of these kids are coming kind of right in that kind of perfect window when we're expecting that their language to really blossom. And so if we
Mhm.
kind of are starting to make interventions a little bit after that, then there's going to be a lot of catch up in terms of trying to get their speech back on track.
Okay. Let me remind people again, we've talked about Jockey Being Family, but I also wanted to talk about our partners. And these are agencies that believe in our mission of providing unbiased, accurate information and wanting it to, and both pre and post adoption. One such agency is Spence Chapin. They are a licensed and accredited nonprofit adoption agency in the New York City metro area. And they've been offering adoption services for more than 100 years. And they are known for their post-adoption services. And they cover the entire triad: birth parents, adoptive parents, and adoptees. And they really have a stellar program for post-adoption, regardless of your role in the triangle. And that is Spence Chapin. All right, so let's talk about urogenital issues. What does that include, and how common are they?
Yeah, so it's a great question. I think the most common one that we see can be kind of break into two categories. One would be that we see something called imperforate anus, meaning that the kind of the outlet for the large intestine, so the way that a person has a bowel movement is closed, and so would need to be opened. And then the other kind of category would be that their genitalia does not appear kind of the way that we would expect based on their chromosomes. So if chromosomally we think that they're a girl, or more often what it is that we say that they have XY, so that they're a boy chromosomally, but the genitalia is a little confusing in terms of that we don't see kind of the penis and the testicles the way that we would expect. Um, and so those are kind of the two main categories. When we go down kind of the imperforate anus category, so that is something that can be associated with a condition called VACTERL, which stands for vertebral, anal, cardiac, tracheoesophageal, renal, and limb. And this is what we call an association. So it's not a syndrome. So we don't know, it's not like a genetic cause that causes all of these things. But for kind of a reason that we don't fully always know, that child has all these different kind of abnormalities in different parts of their body. And so if a child has VACTERL, then we target the interventions and treatments to the different abnormalities they have. Cognitively, those children shouldn't necessarily have any kind of restriction in terms of cognitive development and growth. The one thing is for the imperforate anus, depending on kind of the severity of that, those children that I always kind of warn families may not ever be able to be continent, like in terms of being toilet trained. So of course could have implications for, if you have someone who is cognitively, kind of the match to their peers, but still having to wear diapers, that has kind of their implications for older children and adults for sure. And then when we look kind of down the line in terms of ambiguous genitalia, so that falls into kind of what we think of disorder of sexual differentiation. And this is getting a little bit too into the details, but all of us physically, as like a unborn infant, start out looking more like a female, and then for the boys, their body starts producing testosterone before they're born, and it's the testosterone that causes some of the kind of organs to emerge, so that when they're born, they look more physically like a boy, as we would expect. And so for our kids that have this DSD, the disorder of sexual differentiation, something has happened to the pathway that includes testosterone, so it's not produced, and so that just never happens. So oftentimes those are the kids that, at least the files that I've seen, it has been picked up. So they'll have chromosomal studies that have been, made available to the family to say this child has chromosomes that are XY, but they look more kind of what we call physically like female in terms of in their diaper area.
So what would be the treatment there? Because if the child is chromosomally male but physically female, how do parents approach that? Because at this point,
Yeah.
you don't want to predetermine, and especially because you don't know how the child is going to identify at that age. I mean,
Right.
yeah.
So yeah, that is that you actually just provided the answer. So historically, we used to be a little bit too aggressive and say, well, they look, quote unquote, female, so we should start doing everything to kind of make them kind of complete that quote unquote transition. Now we know from our experience that that is not the kind of the correct pathway, in the sense that as a young child, we will always try to help to, or recommend that they establish with endocrinology to figure out kind of what was the cause that their body's not producing the testosterone. And make sure that there's not other things involved in terms of other like growth hormone deficiency or endocrine kind of hormone deficiencies that need to be addressed in the immediate period. But assuming that those things are okay for young children, there's not necessarily any specific intervention that needs to be done. It's more kind of allowing the child time to kind of start to develop their own gender identity. And then as we get closer to puberty, and then that would be when we would think about maybe offering more kind of hormonal supplements. And either, if they wanted kind of their appearance to be more masculine or feminine. So like if the child says, well, I am chromosomally XY, but I identify more as a female. So then when we start to hit puberty, we'd have to figure out how do we help their body to not produce testosterone if that pathway has kind of reestablished. Or on the flip side, how do we provide them with testosterone if they identify more as wanting to be kind of male?
Okay.
So it's easy for me to say. It's not easy for the families necessarily, but it would be something that for sure families would need to be comfortable with, that ambiguity, and letting kind of their child guide in terms of how they develop. And then there are surgeries and treatments that can be done down the road, but they're usually deferred.
Hmm.
And then the other thing too would be, depending on the state, some states now have kind of an option to do like a third gender or kind of non-gender, non-binary. But I'm not 100% versed on all the 50 states. There might be some states that still will ask the family to assign a gender, and so then potentially down the road they would need to kind of change that if the child
Hmm.
more closely identifies with the other.
And one thing that I think families would have to know is that they're going to have to be prepared to help advocate for this child because they
Yes.
don't fit a norm, and that's going to require parental interference and help along the way until the child is old enough to old enough to decide on their own and also to take over advocating for themselves. The good news, though, is that now parents don't have to make the decision until their child is able to start guiding them as to how they feel that they are, how they're identifying. And so that actually makes it easier from a parental point of view, is that the child is you're not having to make these decisions until the child is old enough to start giving you input.
Yeah, right. So it's again kind of the double-edged sword. So the parents have to be comfortable with kind of the short-term ambiguity, but long-term wise, they don't feel like they have to carry that whole weight of that decision.
Yeah,
Because
exactly.
where we know now that part of that obviously should be with the child, that they should be able to have input in terms of how they self-identify.
And I will say, having talked to parents who have gone through this, children do generally self-identify. They let you know what the gender that they think they are, and it's not always ambiguous to them.
Yeah. Yep.
Hmm. All right, now one that we cannot leave this conversation without talking about because it's such an important one, and that is the impact of trauma. Because the reality is, any child who has been, well, especially those children who have been raised, spend any time at all in institutional settings, have experienced some form of trauma. So, what type of impact should parents be prepared for? And let's tie into that the age of the child at adoption.
Yeah, so I think that similarly to kind of what we were talking about with the ambiguous genitalia, we have come a great ways in terms of our understanding of trauma and kind of trauma-based care, and the potential impacts on children. So when children were adopted, and I should have probably mentioned this at the beginning. So I have personal connection to international adoption, and I was adopted from Korea as an infant. And I came home when I was less than a year old. And at the time, my parents, I think the kind of the understanding from the agency was that, oh, if they come home as a baby, we can just nurture them, and we can kind of supersede nature in a way, and they'll be fine.
Hmm.
And they're pre-verbal, and so they don't have any memory of kind of that pre-adoption period. Now we know that that's not necessarily the case, and we've had kind of studies that show that, and this is usually more on the domestic side, but with a domestic adoption, when a child is placed even right at birth with an adoptive family, we know that a child does have a sense of their prenatal environment. So, kind of they're potentially hearing sounds, like the people talk about, baby Mozart, and you can expose kind of the unborn child to songs and they can hear the biological mother's voice. So depending on what that environment is like, if the prenatal environment was very stressful, or there was kind of abuse going on to the pregnant woman, that could have the impact on the infant. And then just even kind of that separation of having, or the kind of the transition of having been used to one environment and then all of a sudden being placed in a new environment with new sounds, and not having any kind of known environmental input, can be difficult for some children. And then definitely kind of the longer that I think a child is in either foster care or institutionalized care, and kind of their sense of permanency is not kind of fully established, there is a higher risk of kind of ongoing trauma or difficulties with attachment and being able to establish those bonds going forwards. We have a psychologist through our clinic who she's kind of the world-renowned expert, Dr. Maria Krapina, in terms of toxic stress and kind of trauma-based care for looking at these kids for international adoption. And we know that from her extensive research that children, when they're very, very young, they have kind of their way to buffer toxic stress would be through typically their parent or their caregiver. For when kids get to be older, so kind of that preteen to teen, their go-to is not necessarily going to be their parent. So that's something that adoptive families need to consider when they're thinking about adopting older children. That it ideally that child will still be able to form a bond with someone, but it might not be with the parents in the setting. It might be another kind of close caregiver or close adult or even a peer in their kind of post-adoptive environment.
Another thing that I think it's important for parents who are adopting children who have been institutionalized to consider is the possibility of sexual abuse. And quite often there is nothing in the records, um, although sometimes there might be. So how common do you believe that is, or how aware should parents be who are adopting children who have been institutionalized?
Yeah, I mean, I would say that if a child is kind of middle grade school and older, and they've been in an institutionalized setting, that unfortunately, kind of the likelihood is pretty high, and so especially if it's an institutionalized setting where there's a wide range of ages, kind of infancy up to some of the orphanages that we see, there's teens that, and you think that those teens now have been there since they were a baby, so kind of have all the potential maladaptive behaviors from that experience. So those are the ones that I kind of unfortunately say um, you kind of have to assume that it's happened. And if you're pleasantly surprised that they haven't had that experience, then that's great. But I would kind of operate on that there's very high likelihood that it has versus the other way around. If it's not, like as you mentioned, if it's not noted, that doesn't necessarily mean that it hasn't happened.
I will say we have a number of courses on parenting children who have been sexually abused. The common assumption that these children all turn into abusers themselves is not accurate, and there is a lot that can be done, but it is something that, again, parents need to realize it will require their involvement in therapy and work with the child. So it's something that they need to go in being prepared to find a therapist that can help their child.
Yeah, definitely. And I think along those lines that, like I was saying, that for if you're considering older, adopting kind of an older, like middle age to older child, I think again operating on the assumption that it's the very high likelihood that either physical or sexual abuse has occurred, even if it's not noted in the chart, and kind of being more proactive in terms of their therapeutic support early on versus if you think, oh, it doesn't have any mention of it, so this isn't an issue. Those are probably the kids that we see that as they get older and start to kind of cognitively kind of wrap their mind around their pre-adoptive experience that potentially struggle more if it hasn't been addressed kind of from the get-go.
Okay, and the last special need I want to talk about is prenatal exposure. I don't want to go into a lot of detail because, again, we have quite a few courses
Yeah.
on every type of prenatal exposure: alcohol, drugs, and tobacco, and marijuana, you name it. So, but if you could just generally talk about how common prenatal exposure is, and then now we use that as a segue into talking about the most common special needs you see from various countries. But first, before we do that, let's talk just briefly about prenatal exposure and how common and the impact.
Yeah, so prenatal exposure is very common, and it does depend on the country of origin, that we see kind of varying degrees. But the one that I want to definitely highlight, as being kind of in my mind the most important, would be alcohol exposure.
Hmm.
I think that oftentimes, because alcohol is so prevalent in our environment, and the kind of social drinking is, for the most part accepted, that when people see prenatal exposure and they see like cocaine or heroin or methamphetamine, they're like, oh my gosh, look at all of these. And if alcohol's on the list, or cigarettes, they're like, oh, that's not too bad. Everyone, we know someone who smokes cigarettes, or has a glass of wine here and there. From a clinical perspective, in my mind, alcohol is probably the one that I'm most concerned about. So we know that fetal alcohol spectrum disorder is the number one cause for preventable developmental delay, or kind of developmental and cognitive impairment. And so that is one that I think, again, we're kind of learning more and more as we go, but it's something that I think that families definitely need to be aware of. And we'll talk a little bit about this with the specific countries, but just for example, I think when more of the Eastern European countries were open, and families were adopting from places like Russia or Romania, and we didn't know, I think FASD was not kind of as widely known at the time. We know that the prevalence of alcohol use among women of childbearing age in those countries is very, very high. So again, similar to kind of sexual abuse, when I would see files from those countries, I would assume that there was alcohol exposure unless told otherwise. But I think that those are where sometimes families find that if they come home and they're young and they seem to be doing okay, that doesn't necessarily rule out that they won't have problems going on, because commonly those types of issues will develop as a child gets older,
Hmm.
and into kind of adolescence and then into adulthood, and can have pretty serious implications, more so than some of these other ones that I think families would feel like initially would be more overwhelming. But I think FASD is by far one of the more common causes that we see that families are struggling with post adoption in our clinic in person.
And another myth that people have is that if a child does not have the facial features of fetal alcohol exposure, that the child has not been exposed, and that simply isn't the case.
Yeah,
Uh,
correct. Absolutely. So we don't know when the facial features completely develop during the kind of prenatal period, but we know that there can be alcohol exposure that can cause brain changes, and they would be subtle. So it wouldn't necessarily be brain changes that we would see by brain imaging, but brain
mhm,
changes meaning cognitive functioning deficit, that there's no evidence of any facial feature
mhm,
kind of
exactly.
impact.
All right, so, I'm gonna start with, prenatal exposure and go through the prevalent, the major placing countries for
Mhm.
international adoption to the US. All right, so how common is, prenatal exposure, alcohol or drugs in China?
So China is very, very low. I think when we think about prenatal exposure, the for alcohol and drugs, the most common countries that we see would be like Central and South America. It kind of depends on, for Central and South America, sometimes we see children that are coming from kind of the native or indigenous kind of population in the area, and so it's less, I think, potentially with some of those subpopulations, but kind of on par, I would say that that's one area. Another area would be definitely kind of again Eastern Europe, so the Bulgaria, Ukraine areas. We
Mhm.
still see high use of alcohol and then other drugs. And then I think sometimes people are surprised, but South Korea now has taken the place of Russia in terms of the number one, like kind of the top country that we see for alcohol exposure.
Mhm.
Not so much the other drugs, but definitely alcohol and some nicotine. And then we're starting to see more pre-adoption reviews coming through from Southeast Asia. So kind of Thailand and Vietnam. And those, I would say, also have kind of a higher likelihood of substance or alcohol exposure.
Okay, excellent. What about African countries?
Usually it's low. Sometimes it kind of depends on the country. So historically, like Muslim countries, that because of religious adherence, they abstain from alcohol, and so we don't see it as much. Like historically, Ethiopia, we didn't see any alcohol exposure, and then the other countries that just the um, kind of standard of living in terms of cost is so low. So I think that's where we see in China, both socially and then the cost of some of these substances is so kind of exorbitant relative to, food and water and shelter. Similarly, like Haiti, and then if country, I'm thinking like Marshall Islands, which is kind of a small program, but that just the cost of these substances, that they're just trying to figure out how to get food
Okay.
kind of on a regular basis. So we're not seeing a lot of extra kind of drugs or alcohol.
And what about India?
Oh, similarly, yeah. So India, again, we don't see a lot of drugs or alcohol exposure.
Okay. All right. So for China, which is the number one placing country to the US, what are the most typical special needs you're seeing?
Yeah, so it's a little bit of a gamut, but I would say that so I talked to Dr. Dana Johnson, who is the founder of our clinic, and one of my mentors, and I kind of think of him as like the father of international adoption.
I
So
do too.
um, yeah, and he has extensive experience in China, and so what he was saying that kind of families can think of is that from China, that the director kind of the orphanage and then kind of the minister of adoption, they kind of have to bless the child's file, as it's making its way to the US. And so they don't necessarily kind of pass a file forward unless they feel that the child is adoptable. So then because of that, there's a high number of kind of surgical or slash kind of correctable conditions. So we see a lot of, heart conditions. We see cleft lip, cleft palate. We do see like albinism or dwarfism, and then kind of the, ambiguous genitalia, and orthopedics. And then we see Down syndrome is kind of the one that I would say would be kind of more quote unquote like the social, kind of social concept of Down syndrome in China is not the same as it is here.
Mhm.
But we don't necessarily see ones from China that would be kind of fall into the typical category of like prenatal exposure or kind of trauma based. So we're not a lot of like sexual abuse, physical abuse, or kind of known emotional trauma.
Even in
That
older children?
Yeah, so it's not noted in the chart, I guess I
Yeah,
should say.
yeah, I was gonna say, but I think, again, given if your child has been institutionalized,
Correct.
okay. So let's, going down the list, India, what are you seeing?
So India, it's malnutrition, and then we are seeing some of developmental delays. So it could be kind of like a CP, prematurity related. We're not seeing so much of the kind of the surgical correctable, but some of the ones where it's a little bit vague in terms of that they have a hearing loss, we don't quite know yet, what that is, or they're having some developmental delay, but we're not quite sure, is it because of institutionalized impact or is there some underlying cause? But not quite the same of the kind of quote unquote syndromes that you would necessarily associate with China.
Okay, what about Colombia?
So Colombia, I would say, is probably much more on the end of the spectrum in terms of like emotional trauma, sexual abuse, physical abuse, and then prenatal exposure. Those are usually older children and oftentimes come with a sibling set. And so there was something that happened to maybe one of the children that, they were removed from the care of their parents.
Okay, what about Ukraine?
So Ukraine, we see a lot of prenatal exposure and developmental delays, all the way from, again, institutional impact all the way to, kind of diagnosable autism. We don't see as much of the kind of conditions that you would see, like the surgical or kind of quote unquote correctable conditions that you might see from China.
Mm-hmm.
The one thing I will say about Ukraine and sometimes from Bulgaria, families might be a little bit overwhelmed because those charts sometimes will come and they have just a whole slew of quote unquote diagnoses. But we call them kind of the garbage pail diagnoses. Like they don't actually exist. They don't really mean much. So that's where, again, having kind of a medical professional help you to kind of piece through and say what's real and what's that they're kind of throwing this on because they feel like something's wrong, but they don't quite know what it is yet.
Mm-hmm. And just the way different medical communities function and diagnose is just different, and it helps to have somebody who's seen a lot of them.
Yeah.
All right. What about South Korea?
So South Korea, the number one for sure would be alcohol exposure. I will say that for other conditions, for the most part, South Korean medical network is probably on par, if not better than what we have available to us in the US. So if there are other issues, like if there's congenital birthmarks or heart issues, seizure disorders, they are getting typically exceptional care in South Korea before that they, medical care before they come home. And as I'm sure many families know, South Korea is predominantly a foster care based system. So they're usually with, kind of a more typical like nuclear family with a foster mom and dad and maybe some siblings. So getting a little bit more of that one-on-one attention than you might in some of the other countries.
Okay. How about Haiti?
Haiti, we still see a lot of infectious disease and then the impact of kind of chronic or acute on chronic malnourishment. So we're seeing a lot of like some of the parasites, intestinal parasites. And then, like I said, I saw a couple kids recently that had hepatitis B coming from Haiti.
Okay. And then Nigeria, I think, well, let's say Nigeria, and then if you can extrapolate to other African countries, which you might not be able to, I don't know. But
Yeah, and we haven't seen a lot that I am aware of coming from Nigeria, but I would say that
let's just talk African countries.
yeah, again, I think probably similar in that it's maybe malnutrition. We have seen some older kids coming from Africa, and so it's a little bit of kind of a hybrid of malnutrition plus potentially periods of homelessness, some abuse, and then trauma based on how they came to be in the kind of orphanage setting.
Okay, excellent. So in general, the take-home message is post referral before when you're in the application standpoint. Do your research, read up on what the special needs, because you're going to be asked to fill out a form in international adoption, is check off a list of things you are willing to consider. So listen to this, and then also do your own research. But then after you have a referral and you have medical records on a specific child, get yourself and the medical records to a doctor who specializes in adoption medicine.
Yeah, I think that that's key, and I would say that at a minimum, if you can get the records reviewed by a medical professional, but and obviously I'm a little biased, but I think really the best would be to get your records to someone who specializes in adoption medicine, because we have kind of the benefit of, since with the volume that we see, we are able to kind of spot the trends before they are kind of a known trend.
Exactly.
And and then also we are aware of kind of the questions to ask when you're kind of reading between the lines. So if you're being told that a child is, quote unquote normal or developmentally on track, but then we can help the family to ask a little bit more pointed questions or ask for more pointed assessments and results to piece out if that's necessarily the case or not.
Yeah. And your adoption agency should be able to recommend an adoption medical professional. And I would also add that they don't have to be a professional that is located near you. Every adoption medicine clinic I know of accepts, you can mail or not mail, listen to me. You can email scan and email the chart to them, and then do the assessment over the phone. The advantage of choosing a clinic near you is that once a child is home, you can go back to that clinic and have care there as well. But it's not necessary for the post referral evaluation of medical records. So, yeah, so keep that in mind as you're moving forward. And I believe there is a list. Um, the American the Pediatric Association has a list of medical doctors who specialize in adoption medicine.
Yeah, definitely. And then also, we have found some families, if you are willing to travel, I know that all of the clinics naturally would be happy to see you. So, similarly, on the post adoption side, if possible, we do see value in seeing an adoption medicine specialist for that kind of initial, post adoption
Mhm.
visit. We
Once the
typically
child's home,
recommend,
right? Mhm.
yeah, we typically recommend that about 2 to 3 weeks after a child has come home. So we have had some families that are, thankfully willing to travel. We've had families that even come internationally. Like we've had families coming from Germany and South Africa and South America. And not to add extra, visits onto a family's already busy schedule, but oftentimes those visits for the adoption medicine evaluations can be done annually. So not so sometimes families will kind of tack it on with a fun trip or whatnot to
Okay.
different parts of the country.
Well, thank you so much, Dr. Kimara Gustafson, with the Adoption Medicine Clinic at the University of Minnesota, for talking with us today about common special needs and international adoption. I really appreciate it.
Yeah, thank you for having me.